Welcome to our MRA webinar titled Medical Record Documentation Querying, Meeting and Maintaining Compliance. There's a brief disclaimer for your review. I will not read that through today. On the webinar, you'll have it in your handout packet. I'm Gloryanne Bryant, today's presenter, and have an RHIA, CDIP, CCS, CCDS, and an AHIMA ICD-10-CM PCS trainer. You can read this bio also on the slide. So again, welcome to today's MRA webinar. And our goals for today are to look at the different types of querying. When to query and when not to query, very important. Reviewing clinical indicators and the rationale for a clinical validation. Enhancing your knowledge and understanding of the query process and having compliant querying. Improving skills with some case scenarios to review and discuss virtually, as well as understanding key strategies for improving your query process and compliance. Clinical documentation, that's where we have to start. Clinical documentation, as you know, reduces risk management exposure, and clinical documentation and the goal of the query is to obtain the necessary documentation to reflect the provider's rationale or clinical decision making. This supports medical necessity. This tells the patient experience and their truthful medical story. Clinical documentation is a communication tool with other healthcare personnel. Clinical documentation can help reduce risk management exposure. It is linked to quality scores, outcome scores. And yes, it drives reimbursement for services and care across the continuum of healthcare. I wanted to share with you this screenshot of a CMS booklet, Centers for Medicare and Medicaid Services fact sheet regarding documentation. The title of this great resource is Complying with Medical Record Documentation Requirements, and you can download this tool. I've provided the link here for you. I highly recommend we have this tool, go through this tool. Although it's designed to talk to providers, there is a lot we can utilize and learn from this particular fact sheet document. So as we go through these slides, I want you to be thinking about clinical data, coded data, as we go through each of these slides. Put that in your mind. There may be a couple things I will mention that maybe are actionable bullets that I want you to maybe make a note of and check within your own CDI program. Clinical coded data expands beyond statistical reporting in the DRGs for accurate depiction of clinical scenarios. It goes beyond that. Coded data becomes administrative, and it's used to measure the quality of care. It's used for research, public health, and we certainly have used a lot of clinical data during COVID. Clinical coded data is used to validate medical necessity. It's also used for risk management and litigation, very big in the medical litigation area. It's also used for public health and research, as I mentioned. And today, almost everything that's documented in that health record, that encounter, is translated into either an ICD-10-CM, PCS, or a CPT, even a HCPCS code, emphasis on code, which equals the data. We are very much a code-dependent healthcare system in the United States. And I want to call a shout out and thank you to the clinical coding translators, those coding professionals who do that translation process, and how important you are to our healthcare world. Documentation used for coding and the query of documentation and coding has been around for years. In fact, my experience, I can recall having queries back in the 1980s, and certainly on with CDI coming on later. So when we think about the coding query about documentation, yes, it's been years and years in the profession and around. Communication tool is the query. Think of it that way, as a communication. But it's also a process to clarify medical record documentation to support the code assignments that you are going to assign for that given encounter. And those encounters include both inpatient and outpatient setting. Have a formal process. Determining the query is needed. Submitting the query, tracking the query, checking for follow-up of the query, and then closing out the query. You should have actionable element here, so make a note. Do you have a written policy and procedure for your query process, whether it be a coding query process from the coding professionals or your CDI professionals? You should have a written policy and procedure, and that includes the step-by-step process that you go through in initiating, determining, and so on. We can use formal templates for queries, and those are available if you've not looked at them at the AHIMA ACDIS examples they have put together. Those are two professional groups that do a lot around querying and publishing best practices, toolkits. And our documentation query can be generated by or from either the coding or CDI professional. So what is the query? That's a common question, especially when you're talking to providers, clinicians. Well, what is this query? Well, we have to think of it in the context of a clarification or a question request, kind of a requesting process that is sent or delivered to the provider, the physician, nurse practitioner, physician assistants, etc. I've seen queries even to the wound care nursing staff or even physical therapy staff. Now, we have to keep that in context of who is legally responsible for the care of the patient and determining a diagnosis. Based upon our coding guidelines, we know we can use certain documentation for diagnosis, and then documentation from other non-physician providers we can't. So we have to follow that. And we have to also think about the synonymous terms for query. Yes, that word clarification comes to mind, and I've seen a lot of, quote, queries titled clarifications. They can be called clinical clarifications, documentation clarification, documentation alert, or similar terminology. And when we talk about a compliant query, that should be each and every time a query is initiated, should be compliant, is often the primary medical record communication tool to explain the appearance of documentation later in the stay, the admission, or the discharge. So we want to make sure they're compliant. We want to make sure that they're coming from the right or going to the right provider. And queries continue in today's healthcare to be a mechanism that increases the precision of our medical record clinical documentation, which then is translated into our accurate clinical codes. Our CDI programs, our formal CDI programs and departments, are crucial to clarifying and validating that the documentation is appropriate and accurate. A lot of education and training goes into the CDI staff so they know when and why and where to obtain the additional clarification of documentation so that it's accurate and compliant. It is a known fact that reimbursement is driven by coding, and coding is driven by the documentation. So we have this link in this kind of a linkage, but it's circular, doesn't it? It goes around and around. When we have an encounter, we have documentation, we have coding, and we have reimbursement, and then we go back and we have an encounter with documentation. Having compliant clinical documentation will support the quality of care reporting that is required in today's healthcare industry. It'll capture patient severity and acuity, risk of mortality. Sometimes we call that severity of illness, SI, or the risk of mortality, ROM. And documentation and coding tell that patient story. That's one of the key things that I really, really want to emphasize. We help tell the true compliant patient story with the documentation and coding. And again, the clinical notes tell and explain the patient experience along with that story. Thinking about querying the data that accurately reflects the clinical scenario and the provider's intent within the constructs of the code set. So we have a lot within ICD-10, CM, and PCS in the hospital inpatient setting that we have to think about when we see the documentation in the hospital inpatient record in particular. Querying provides a unique opportunity, and I want you to think that way, that it's an opportunity. Don't think of it as a chore, but an opportunity. And we must understand the clinical scenario that is being presented by the patient encounter and the provider's intent through the clarification of the documentation in that medical record, whether it be a query that is written or verbal or a query that is electronic. And a query must follow established guidance and guidelines found in the American Health Information Management Association and the American Clinical Documentation Integrity Specialists Organization, and they together present the practice brief, an industry standard, in 2019. And I've provided a link on the slide that you can go to read the full practice brief. Every CDI program department should review, utilize this practice brief as a foundation for a compliant CDI and query process. And in that brief, they explain the purpose and how it's being utilized. In fact, I can tell you that I've talked to a couple regulators conducting investigation in some encounter discrepancies with coding and documentation. And it was this practice brief that they utilized when they saw queries to ensure that the queries were compliant. So it really is a strong document for us, a best practice for us to utilize. When querying, we must present only the facts identifying why the clarification is needed. Never mention or list the impact to any reimbursement payment whatsoever, nor should you mention the impact to any quality scores or safety scores or anything like that. We can't make the appearance that we're trying to incentivize the provider through this query and that we are trying to make them document the way we want them to document. We only want a truthful documentation. So the query will bring forth only what the factual information is regarding the patient and the patient care for that given encounter, whether it be an outpatient encounter or an inpatient hospital encounter. Always being compliant with our practices as they're outlined in that practice brief from 2019. There are a variety of types of queries that can be utilized, and you probably are pretty familiar with them: verbal querying, written, paper type querying. There's also electronic queries, written. But there also is artificial intelligence or AI technology that will go through the electronic health record, and based upon the programmed algorithms looking at clinical indicators will generate a potential query. They'll use the documentation that is present in the medical record, including lab and meds and so on, to determine whether something should be clarified. Now, human intervention there is certainly always needed. And a lot of clinical documentation querying is done concurrently while the patient is being seen in the encounter. For a hospital encounter, of course, that can be a couple days or longer, but it can be used in rehab and skilled nursing, physician offices, and as well, which makes it a little more challenging when you have a very short stay, matter of hours, to try and concurrently query the provider. A lot of times those outpatient encounters are done the same day as the outpatient encounter. Another type of query is the clinical validation query, where we are focusing on the clinical information provided, whether it be diagnostic or maybe surgical information, and we want a clinician to provide verification, validation that that clinical condition, et cetera, is actually present. So we utilize physician to physician or some type of clinician overview review. Coding professionals might have a process in place to send a query to the clinical validation area or person, and they often work very closely with CDI. So they could refer in their process that a clinical validation go to a CDI professional. They determine, yes, they both think it should have a clinical validation, which then would go to a physician champion or provider. But why do we query? Well, as you know, there's lots of interesting verbiage that can be used in a medical record or left out of a medical record encounter, and some people just assume that it's known when in fact it is not unless it is written down. First thing that comes to mind is, of course, reimbursement. We always think about that. As I mentioned, we're a code-dependent healthcare system, but also there are quality outcomes that might be impacted by the documentation being clarified. And although this may not be included in the query itself, it may have an impact to that. Why query? Well, another is to gain supporting documentation that demonstrates quality care and drives accurate and compliant information and quality measures. There are several instructions within our official coding and reporting guidelines that state that a query should be utilized. And I'll cover that a little bit later in the presentation. Also, why query? Well, we can deliver or send this to the provider, the nurse practitioner, physician assistant, who is legally responsible for making and determining a diagnosis, so that we can then obtain the supporting information that we need. Again, why query? These are bullets that can be used for physician education about the query process, or maybe it's shared with the physician or administration of a particular organization or practice. As you look at these, you can tell that yes, they're very important to why we would query and why we need documentation in that medical record encounter to truly tell the patient story so that we can have accurate, compliant, coded data. And another area where we've seen when to query is the health record fails to meet one of the following, fails to meet. So that's kind of interesting terminology. So if they don't have legibility. Now we don't see that as much anymore in the electronic health record, but I can tell you I was doing an audit last summer and it was with medical records that were electronically scanned, but those records were written. It was hard to get back to learning how to read physician handwriting or provider handwriting again after reviewing a lot of electronic records, which we have typed information and is very legible. Completeness, so it's lacking, it's not complete. Clarity, specifics, consistency. If we have conflicting information in parts of the record, it can be by even the same provider, but sometimes it's from the consultant that may be called in and the attending not having the same information or the same diagnostic information. Precision, reliability, and timeliness. And we're going to talk a little bit more about timeliness. So when to query, and when we think about this for reporting purposes, the definition of other diagnosis is interpreted as additional conditions. So in the inpatient hospital setting, when we think about when to query, certainly when we're thinking about other diagnosis, we look for information that may help us in terms of affecting the patient care. Was that condition, potential condition, clinically evaluated or therapeutically treated? Diagnostic procedures performed, extending the length of stay, or increasing the nursing care or monitoring. And these are all ors. So any one of these by definition, could support other diagnosis or secondary diagnosis being assigned. And then that gives us an idea of when to query. When there is a clinical evaluation of a condition, but yet a condition is not documented. When there's therapeutic treatment or services to a particular condition, but that condition is not documented, and so on. Continuing with when to query, it's made in certain situations, such as clinical indicators of a diagnosis, but no documentation of a condition or a diagnosis. Clinical evidence, clinical indicators, for a higher degree of specificity or severity, but it's not documented. Uncertainty of a cause and effect relationship between two conditions or organisms. And that really comes into play with a lot of the coding guidelines and coding structure when we're looking for the underlying cause of a condition can also be coded, or that underlying condition should be sequenced as the principal diagnosis. So when we have uncertainty in this area, that's a huge impact to the codes that could be assigned and the sequencing. When there's no clinical indicators to support a diagnosis that is documented, I mentioned that before as part of the query practice brief too, and an underlying diagnosis not documented for a presenting symptom, that would be when to query. An underlying diagnosis not documented for the treatment that is being provided. When patients are receiving drugs or medications, you could say therapies or IVs or infusions for treatment, or treatment without a diagnosis to support those types of services or therapies. Why are they doing wound care? There should be, right, some documentation of that wound. Also, when to query, determining the clinical significance of several abnormal findings, and that could be laboratory values, or it could be radiology imagings that are abnormal. Now, I mentioned here several, that's a key word, because we're going to talk about when there's just one abnormal finding one time. And what do you do? We'll talk about that in a moment. Continuing with when to query, you can see there's lots of different scenarios of when to query. Establishing acuity. When we have a past history of something, a condition, we have to determine if it's active or is it now resolved. So we might have to query regarding that. Determining the intensity of patient evaluation, treatment, and description of medical decision making. This is a big one that can tell you when to query about an evaluation and management CPT code, in particular in our outpatient setting. Clarifying diagnostic and therapeutic procedure, treatments, and tests. When to query when there's a lack of any changes in the patient's condition, including psychological and physical symptoms. Any documented changes. Just says the patient's fine day after day after day, but we really need documentation to describe the patient's change in condition. Assisting in identifying any follow-up instructions or discharge planning. Sometimes we have conflicting information between the discharge planner, the physician's order, and where the patient's actually being discharged to. So when to query could include that as well. And clarifying each new or active condition, disease manifestation, severity, cause and effect, complications, even, or potential complications, when to query to clarify those. I've included a screenshot on this slide that's from the ICD-10-CM official guidelines. And why this is here is it tells us to query. Yes, the official coding guidelines under excludes 1 do tell us to query. And I've encountered a couple times in my career, I don't want to say couple, I'd say maybe a handful of times, where a particular practice or department said, we don't query, we won't want to bother the doctor. But what do you do about an official guideline that actually in the scenario you have in your medical record encounter tells you to query the provider? Are you going to ignore the official guidelines? That would not be compliant. So I want to emphasize that you should have a query policy. Absolutely. Any setting, physician practices, clinics, SNF, rehab, all of them should have a policy around querying that support and follow the official guidelines. I've gone through the official guidelines further, and you can see here I've kind of put in bold a couple other times. Guideline 12 does tell us to query the provider. Guideline 16, documentation of a complication, says to query the provider if it's not clear. Guideline 17 also tells us to query the provider. These are very important coding guidelines that you have to be aware of because they could fit into several different scenarios and medical record encounters. So once we look at the official guidelines, you go to chapter-specific guidelines, and yes, they're there as well. I'm not going to include all of them, but I'm giving you an example here of Chapter 1, specific guideline around acute organ dysfunction that is not clearly associated with the sepsis. And we have an instruction to query the provider. Under severe sepsis, it tells us that this is a complex situation when we have severe sepsis. So querying may be necessary to be provided to the provider prior to the code assignments. And then in Chapter 10, specific guideline around sequencing of acute respiratory failure is another example of the official guidelines telling us to query the provider. You may wonder about ICD-10 PCS, or the procedural coding system used on the inpatient setting. Does it ever tell us to query? And it does. Excuse me. I've highlighted here the only spot in the PCS guidelines that does tell us to query under guideline A11. Take a look at that one. So that brings us back to the AHIMA ACTIS practice brief from February 2019. It really does help provide guidance, a process for querying. Its title, Guideline for Achieving a Compliant Query Practice, has become an industry gold standard. Regulatory investigations have used this as a resource, as I mentioned. Queries are utilized, and they recognize that, to help support the assignment of a code. And it can be initiated by coding staff or CDI staff, quite often are the two areas. Now, one of the things I wanted to share with you on this particular slide is the bolded area of one of the bullets. If you look down, queries may be necessary for, but are not limited to, the following instances. The bolded the third one down, third one from the bottom. Query may be necessary to seek clarification when it appears a documented diagnosis is not clinically supported. Now you may think, oh no, we can't do that. Yes, you can. Under this practice brief, which is the industry guidance, when we have a diagnosis documented and by our education and knowledge and expertise, it's not clinically supported. We're not challenging the physician's clinical determination, but we're asking for clarification. And this may be an opportunity for you to escalate to a clinical validation, but you don't just ignore it. You need to address it through the query or clinical validation process. Coding Clinic, the American Hospital Association Coding Clinic, also tells us to query. So I've gone through last year, the 2021, and looked at several examples that they've provided. Now I'd like you to go back and look at these examples. So if you look at Q1 of 2021, there is a situation of a patient with a history of seizures admitted to the hospital, and due to the syncope episode and possible seizure activity, the documentation on the final diagnosis, it says likely pseudo seizures, and how should pseudo seizures in the patient with a history of seizures be coded? Since the patient has a history of seizures, they tell you should query. So you should not assign a code right away. You need to clarify it. In Q2 of 2021, there was clarification of lead placement in the bundle of HIS, and the query the provider is answered here as well. In Q3, here's an example of querying the provider regarding mental health conditions, since there is no provider documentation that the mental health conditions or the treatment affected patient care and management. If the medical record is unclear or ambiguous regarding which conditions affected the care and management of the patient, you should be querying the provider. And just to share with you this summary I put together going back last year and looking at the coding clinics, 6 times in 2021 Q1, they mention querying the provider. In Q2, 5 times in coding clinic, it was stated. In Q3, 2 times during that quarter. And Q4, the last one of 2021, 4 times they gave instructions to query. So this is not unusual. It's very common that our AHA coding clinic, which is an official source for ICD-10, CM, and PCS, tells us to query, similar to the official guidelines. Another important aspect of all these slides prior are telling us to query. What about not to query? Well, when there are normal diagnostic and other findings, so it's normal, then why would you want to query, right? So that's one particular scenario. You have to think twice when that happens. When a person is ill, when a patient is ill and they're taking medications or having tests done and conversations, that's stressful. And an abnormal lab finding can occur, like even an elevated abnormal blood pressure can occur once, maybe even twice during this stressful situation. Do we need to query every time blood pressure is elevated just once? No. So you have to really look at the clinical significance and the circumstances of that abnormality, because the patient may be taking medications that have made them feel not so good and changed their particular chemistry. Also, documentation does support a symptom or appropriate treatment for a given diagnosis. If the documentation is there that supports it, don't query. And if you missed or avoided reading parts of the medical record, this is a big one. You didn't read the whole record, and there it is on another part of the record, the answer. And this is one that makes physicians not very happy, is he or she already has documented the information. You just didn't see it because you didn't read or review the whole record. So make sure you're being very careful when you're querying, that you haven't missed or avoided some part of the record. It could have been in the progress note or a therapy. And really check to see if our query is conflicting, because there may be documentation there. The attending physician needs to be looked upon as that primary source for the documentation for that stay, that the attending physician has the responsibility for that ultimate documentation. When not to query, clinical indicators are not present in the documentation, so there's no clinical indicators there. So we need those clinical indicators to support the query itself. When there's no documentation supporting that there is another or additional diagnosis, then why are you querying? Do not query. Guessing or second guessing that the patient has something, not our job, right? So we have to have clinical indicators. We have to have something to go on. We can't just be grasping at straws or air. The encounter date and the query date are very, very far apart, meaning the querying is way after the encounter. More than 30 or 60 days apart sometimes can raise a flag. So here's another one to make a note of. Do you have a policy on the timeline for your encounters? Now, you might have different timelines for different types of encounters, such as outpatient encounters. AAPC literature has stated 48 hours of an encounter for an evaluation and management CPT query, where we've seen in DRGs that we can rebill a DRG 60 days after the remittance advice. We can go back in the record and make an adjustment. So there may be a little bit different timeline for different encounter types, but they need to be very compliant. They need to be as close to the encounter end date, discharge date, end date as possible. Also, when not to query, physician negativity towards query. So you know you have a physician that's not going to answer the query or get angry about the query or verbalize their anger to you through an email or electronic response or verbally. Then you need to bring in the physician liaison. They can look at your query, the situation, and determine, yes, I, the physician liaison, physician champion, will go speak to that physician. So you shouldn't be querying. Let the physician liaison do that. Do not query when the provider has already documented the condition, sign or symptom, and it's not clinically relevant. And they state that, not clinically significant or relevant. Then don't query, because that can create anger and frustration and confusion with the provider. Again, that financial information do not include in the query. Don't be giving financial money reward gift cards for documenting certain diagnoses. If you document that the patient had aspiration pneumonia, we're going to give you a $10 Starbucks card. We shouldn't be doing that. No, 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 don't do that. Also, for quality indicator scores, do not include those or a MIPS, which is the outpatient physician scoring. And then utilize that AHIMA ACTIS practice brief. They give examples of non-compliant querying, and they're listed, 3 of them are listed here for you, but go to the practice brief and review the whole content. So in that decision process, practitioners document a diagnosis. What happens when it doesn't appear to be supported by the clinical indicators? Well, as a coding professional, or you have a couple of choices, right? I code the diagnosis because it's documented. End of story. Oh, maybe I do the opposite. I ignore the diagnosis and I don't code it. Or do you take action by generating and sending a query to the provider to confirm the diagnosis? This would be the right action to take. You could take action by saying, I'm requesting a clinical validation to be conducted if it's appropriate, or request to move the query to what we call an escalation process to your physician practitioner liaison. When we're querying, we are utilizing encounter information. Now, using previous encounter information or workup in an outpatient setting may be referenced in queries for clinical validation or clarification if it's pertinent to the present encounter. It is inappropriate to data mine or mine, it means electronically scan previous encounter documentation to generate queries not related to the present encounter. And also the timing, as I mentioned, of the query. There's concurrent while the patient encounter is there, pre-bill or prior to the claim. So the patient's been seen, it's finished, but we haven't billed it. We could look at that pre-bill. And there's retrospective after the claim's been submitted, but use caution, especially retrospective, because you don't want those to be far away from the encounter date. That's a red flag with regulators. Now, verbal querying should be documented and tracked, just like your use of the other queries should be documented and tracked. And our format can be open-ended, multiple choice, yes or no, and those are acceptable practices. With our written electronic verbal query, clear, concise, non-leading, the title of the query should not be leading. So the title of the query shouldn't say anemia diagnosis, unless the anemia is already documented and you're clarifying the type of anemia the patient has. So you have to be careful there. Cloned notes and assessments can be query vulnerabilities. This occurs when providers, nurses copy and paste information from a previous visit or another part of the visit into the current information without verifying its accuracy. And in many cases, details are completely inaccurate or omitted entirely. They're taken out of context. They're also often a mismatch between the chief complaint and the history of the patient. So you have to be very careful, and you should have a policy and procedure around cloning or copy and paste. Now, we have to make sure we have an analytical eye. CDI specialists and coding specialists really need to have an analytical eye and look at this documentation from the perspective, especially when it's cloned. An electronic health record, often cloned notes, copy and paste are in a different color, different font, and that can give you a heads up of that this was brought in from another encounter, another date. Another query vulnerability is using smart phrases or dot phrases in the electronic health record. You have to be careful about these because one little finger stroke can create a whole narrative sentence and diagnosis. Sometimes it makes suggestions. The EHR will make suggestions of a diagnosis to a physician. We have to use caution here because this could create problems. And prompting physician for a specific So not only will they suggest, they'll prompt for this specific diagnosis and tell them to include it. Quite often, because we're humans, we just want to appease the question, and so we'll add that information. It may not be accurate for that encounter. Also, computer-assisted documentation, artificial intelligence can create incorrect diagnosis. I've seen that happen a couple different times when they were talking about in the narrative medical record of the patient's family history of diabetes, and it got construed that this patient had diabetes. So the AI, this computer-assisted documentation, was suggesting diabetes be added when it shouldn't have for that patient. Not having written policies and procedures is making you more vulnerable, more compliance risk. So you should have a step-by-step process. Now, within ICD-10-CM, the diagnosis specificity is very important. So I've included some things here that might be able to help you understand the particulars around diagnosis, specialties. Do we query around laterality? Well, might be a good idea because we do have a new edit in place in our claims processing systems around laterality. So certain conditions do have information specificity in the character of the code to capture laterality. How about the manifestation of a disease, the anatomical location? These are all areas of specificity that queries need to be in place, or we have to be careful how we're using the queries. Unspecified CPT codes may prove to be a particular problem in a particular physician practice. So we have to be careful about those and say, well, why is this particular encounter using unspecified? Shouldn't there be documentation that's specific? And risk adjustment under Medicare Advantage Part C can be a focused area. Also, vulnerability of all these things around diagnosis code vulnerability and several of the informational slides we've provided to you today. Medical necessity is an area that query vulnerabilities can be in place and exist in this. Sometimes physicians don't understand medical necessity rules. The national coverage determinations, are you looking at those and understanding them so that in a lot of your outpatient encounters, we can look at those. Remember, there are local coverage determinations that can exist too, that only cover certain diagnosis. Now, the patient has to have that diagnosis. We can't just pick off of this coverage list a condition and then document it. The patient must have it. And I've seen a couple different times where NCDs and LCDs were utilized just to get the claim paid. And so the physician was utilizing the NCD and LCD with the diagnosis to get it in the record so that they'd be coverage. Now, one of the best things you can do, so make a note, best thing you can do is the query QA, quality assurance, checks and balances, and you should have a formal process for this. Let me say that again, checks and balances. You need to have a formal process for this in place. So policy and procedure. I mentioned that a couple different times about policies and procedures for different areas. This is another one. Maintain a spreadsheet on the status of queries. It should be a tracking tool. You might have software that can help with that. If the query is unanswered, you should have an escalation process policy. Monitoring the query process is an ongoing practice. Week by week, month by month, throughout the year, determine who will conduct this monitoring. Do you have the appropriate staff? Are you going to outsource this to an external vendor provider? That might be something to look at. And how to report monitoring findings and put them into some type of analytical presentation and statistical presentation. And then what is the action to take on certain things that definitely could be improved or changed? You should outline this. So conduct an annual, at least annual quality assurance review on your query process, both coding queries and CDI queries, and budget for this in your departmental budget so that you can have appropriate resources in place. An internal QA auditing, and I've worked in a CDI program where we had the internal QA process. They review frequently, excuse me, and each of the CDI specialists, and this will vary by organization, but you might have in your policy a outline of what the minimum recommendations of this is and how many encounters. Certainly when you have a new employee, you want to review their queries, whether it be coding or CDI. So you want to make sure you're looking at that. Significant changes in coding classification or guidelines. Well, you should be QAing the queries because we're going to maybe have some different perspective. Sometimes we're querying for a specificity because the documentation isn't there, but then we have a new code and it's been well talked about and discussed in provider circles, in society circles, so they know about that. You don't need to query for that as much, but you need to be watching for coding classification changes or guideline changes that would impact your queries, because that should be reviewed then. Changes in the volume of queries, changes in the response rates for queries. The QA review would be detailed medical record review. So it's a detailed review of the medical record, just like done when we have the actual query being initiated. And you can also look at the new treatment protocol. So if you have a new surgical treatment being done at your facility, a new device is being made, or a new wing of services that you didn't, business line that you didn't have before, let's look at some of those records in our QA process of query. And physicians who determine and assign their own codes, their own E&Ms without any review, well, that's a target for you to have some coding or even CDI intervention. The opportunity could be lost to query a physician for greater specificity for an E&M level higher, or telling them to lower it and be more compliant in that regard. So this might be a case for an E&M QA process and query process. When the physician is outside the norm in a CPT E&M ranges, you should be running those. Check the data, and this might be an opportunity for querying, an opportunity for educational intervention, and you'll need a QA review process of those queries as well. So query frequency, query volume, and reporting the findings, again, even if they're outpatient E&M reviews. If you look at the query monitoring and auditing portion of the AHIMA practice brief, it talks about monitoring process and auditing process. You can make these pretty simple. So I'm thinking of a spreadsheet with the status of the query, the date it was initiated, the date it was rechecked, what physician, some patient identification, medical record number, date of encounter, and provider name. And then if there was an escalation process, yes or no, and if the escalation process, what was the outcome, correct, of that. So there's quite a few things you can do there to really monitor queries and audit querying. I alluded to the escalation. So in the AHIMA Actus Practice Brief, that calls on organizations and facilities to create an escalation policy. Here's another one, got to have a policy for. And it should be a standardized process for instances when questions or queries regarding clinical validity arise. Because the CDI specialists and the coding professionals are not part of the treatment, the care team, any such inquiries should be vetted with a manager, or maybe it's your CDI committee or other supervisory personnel for assessment and review before you do that. Do not overutilize the escalation process. I gave some advice on a case, a legal case, where there was overutilization of the escalation process to the physician liaison, and then the physician liaison to the chief of staff, and they felt the physician on the receiving end felt very pressured to document a certain diagnosis due to that over escalation. So use caution. Per AAPC, failing to thoroughly document signs and symptoms, assessments, and treatments of chronic conditions really creates a ripple effect. So develop an escalation policy for an unanswered query and answer staff concerns regarding the query process. So it's going to be very important to take your process to the Med Exec Committee. Make sure you have physician approval and buy-in into this escalation process. The other portion of your queries is around retention, retaining your query. So policy and procedure here as well on retention. Each query practice should develop an internal process. If the practitioner documents his or her response only on the query form itself, then that's the query with the information on it. So you better retain that. So usually the policy around this talks about that the query becomes part of the medical record. And that would be something important to consider. Under the retention, I was instructed one time by a compliance officer, we have nothing to hide with our queries, so they wanted them part of the legal record. We wanted to make sure the impression and the perception and the actuality was these are compliant queries, we have nothing to hide. So they were part of the legal record. And queries should be transparent and retained. Retaining written, templated, and verbal queries. Remember, your verbal queries are going to be tracked, so you'll have evidence of that as well. And in this current climate that we are with a lot of regulatory fraud, waste, and abuse scrutiny, and contractor reviews, etc., it's a good practice to maintain them. That is a best practice. So retention policy and retain those queries. Clinical indicators, very first few slides when we were talking about queries and clinical indicators. Here's where we want to really determine whether we need to query or not. So if you have consistent lab imaging and treatments, those are part of your clinical indicators. You can refer to these, have a particular finding or results, that ongoing abnormalities have occurred in some of these studies, or this treatment was provided and this medication, but we don't see a diagnosis. Those are clinical indicators. Yeah, you would use those to query. The patient's response to treatment, symptoms, observations, objective data like the vitals and the height and weight of the patient. If the patient's really losing weight, this may be an area where it's a clinical indicator of a condition. If there's dietary documentation and treatment and diet has changed to liquid and so on, these are all clinical indicators that are going to be very useful for you, not only as your main primary diagnosis, but also for secondary additional diagnosis. Under clinical validation, that term was introduced by the Centers for Medicare and Medicaid Services back in 2011. That's when it kind of got some importance. And it was around the RAC auditors, recovery auditors' scope of work. They described that the RAC auditors would do clinical validation in addition to DRG validation. So there is a difference with that. And it's important to recognize that the process for clinical validation differs from the process of DRG validation or coding validation in the hospital inpatient setting. So it's important to recognize that we're not challenging the physician's impression, but we're asking another physician to take a look at the clinical picture of that patient and determine what diagnosis appears to be supported. So this is usually performed by an individual with clinical expertise and knowledge. Before querying a clinical validation, ask if there is a reason for it. This will take collaboration and establishing a formal and detailed clinical validation process. Here's another place for a written policy and procedure. This process can be challenging for most organizations, but it's important that each organization create their own policy and procedure related to clinical validation process in both the inpatient and the outpatient setting, and base it upon industry guidance as established in the ACDIS and AHIMA practice brief and other practice briefs that have come from those organizations. Make sure that we're working in the role of the query professional and not expecting to establish a diagnosis. So the provider can help with this. Another provider, another clinician can fill the gap here. Let's look at a case scenario. Here we have a 75-year-old female patient presents with fatigue in the ER. She has faint crackles noted at the bases during the ER physician exam. Temperature was 99.2. with reports of feeling tired. She also has a history of chronic kidney disease stage 3, and that's on the H&P, and a diagnosis of pneumonia, unknown organism. The chest x-ray was noted, low lung volumes and bilateral infrahyoalveolar infiltrates, and checking creatinine, UA every 8 hours, and renal ultrasound. So they say that they started the IV antibiotics, continued for a day and a half, and the chest crackles decreased. She was discharged on day 2. So this was a hospital inpatient stay, a 2-day stay with significant improvement in her fever, no fever. Final progress note states CKD stage 3 now stable with community-acquired pneumonia, is improved, treated with the Zithromax. He got a Floxin. He's got some other, a mini bag. A progress note document states avoided the nephrotoxic drugs, so they didn't give her any drugs that would affect the kidneys. And then the respiratory therapy saw the patient, and then we'll have a home health assessment ordered. So they discharged on oral antibiotics and follow up with the MD for the CKD. Length of stay, 2 days. So what are you thinking? Well, before you jump at anything to query, you have to ask the question, to query or not to query? And what do you think about here? Well, we know that the patient had, right, some problems in the respiratory system. They had a pneumonia. They have a history, and they have the current condition of chronic kidney disease stage 3, and it's moderate. So our official coding guidelines tell us that two diagnoses equally meet the definition of a principle. So were they equally met? You have to ask that question. And you have to look at the treatment that the patients were given, how they were evaluated, how they were treated, and look at the circumstances of admission. What was performed on admission? Did they give IV fluids? And they received a renal ultrasound. They were looking at some things with the renal condition, but they ordered respiratory therapy, IV antibiotics, right? In that, they were doing a chest x-ray. They were checking the lung volumes. So it looks like the patients were pretty close to being fairly equal. So we have to ask those questions. Are they truly equal? What were the circumstances? Do we need to query anything? And I'm not going to give the answer because I want you to think about that one. Let's go to case number 2. We have a 74-year-old, and they have the DLPCL, abdominal lymphoma, was presented with weakness, fatigue, poor oral intake 2/2, severe oral and esophageal pain with food intake for 2 weeks, and melena few days. The ER documentation shows that they have a temperature of 36.3, pulse is 122, respirations 20, WBC 5.5. Urine and blood cultures done on admit were negative. Some appearance of dehydration with blood pressure low of 98/60, documentation of septic shock present in ER. A GI consult and infectious disease consult were ordered. They were admitted on 11/10. Dietary consult was ordered. They were treated on the 11/11. Improving, the dietitian saw the patient and fluid diet started, liquid diet started. On 11/12, progress note remaining, improving, and will discharge today. The ER infectious disease state septic shock on admit, recommend fluid diet for next 4 to 5 days, discuss treatment plan with the oncologist. So what do you think of this one? Presents with weakness, fatigue, and oral intake, and pain, oral and esophageal. So before you use query or no query? Think about that. Do we need any documentation to be clarified? Was SIRS met? Was there localized infection? Was there organ failure? What was present on admission? So those are things to ask. And does the guideline for code assignment and clinical criteria be met? Do we need clinical validation query? There was no documentation of the word sepsis, but there was septic shock and dehydration. So we're not going to answer that one either. It's a good one to think about, and you may see that in your own experience. So how about query fatigue? Well, yes, not only does the provider get too many queries, but maybe we're generating too many. Is there redundancy in our queries causing a lack of provider participation and response? So we should be tracking the number of cases that we query on, know our statistics, and identify ways to decrease redundancies. Maybe there needs to be provider education. Maybe we need to have our physician liaison or champion talk to physician or a specialty group. Double check before you query. Ask that yes and no question. Identify pitfalls in the clinical indicator piece when you apply that. Query over and over again for the same thing. Then education is needed. Define compliant verbal queries, because we shouldn't be suggesting a diagnosis in our verbal queries. They need to be compliant too. Identify query best practices and have your QA process in place. Remember, the query process, when and when not to query. The process of querying a provider is an essential mechanism to improve data quality, documentation, resolution, and provide reimbursement. This process is also an effective approach to obtaining complete and concise information required for coded data. Querying can help identify patterns of poor and inadequate documentation. It can be a good thing. Remember, an effective query process will bridge a gap of communication between coding professionals and providers and CDI. This process is a winning solution for physicians, coding professionals, CDI, and healthcare organizations and practices. Know when to query and when not to query. The process that we put in place needs to be compliant. Remember, when implementing an effective query process, physician office practice, we need to demonstrate improvements in the quality of our coded data and meet the needs of the healthcare compliance in the organization. Remember also that a query is a powerful tool. Work with providers. Dialogue. They want to understand our needs and our requests. How are we wording our queries to the providers? We want to make sure we're leaving it up to their clinical judgment. There's an example of, based on your clinical judgment, can you provide a diagnosis clarification represented by the clinical indicators listed below? Not challenging their clinical judgment or knowledge. There are many benefits besides financial, so we can't always rely on those and make them the center of our CDIR queries. Non-leading, timely, non-financial base. The query written just to confirm a diagnosis will not be enough to prevent outside auditors. The goal is to obtain the necessary documentation to reflect the rationale of the provider and the clinical decision making. It's possible to read too far into the clinical documentation and make connections that don't really exist. Before submitting a query, stop and consider its appropriateness. Ask, should I query or should I not? Some next steps include focusing and determining on when and when not to query. Sometimes you even need a second set of eyes. I work with a couple audit teams, and sometimes I get an email and a call that says, I'm going to walk through this case with you. I need your opinion. So sometimes you need that second opinion of someone about whether to query or not query, and not to over query. Collaboration is key. Education is essential. And quality assurance reviews are a must. The patient can and do review medical records today. They can request to look at the record. That record needs to be complete and accurate. Some key resources are listed here that you can utilize and keep in mind when you have query. I bolded a couple that are essential 3 that you must have. Some other resources are listed here, including a couple links to a couple of places. There is a query pocket guide that is out there in the industry that is helpful and useful too. I also included the AHIMA clinical validation example. If you're interested in that, you can take a closer look after today's program. So in summary, follow the AHIMA ACTIS practice brief from 2019 to obtain and maintain compliance. There are different types of queries. We should be tracking and trending all of them, including verbal. Know when to query and know when to not query. Yes, each case encounter and scenario is different. So you just can't make it cookie cutter. We're always going to query on this. You got to look at the case. Timely querying is important. Having a policy and procedure around your query process, your QA process, your escalation process, and your retention process. Establish a QA process for your queries. It can be done internally or externally. Educate. Remember, successful querying and clinical documentation improvement facilitates the accurate representation of the patient's true clinical status, and then that translates into the clinical coded data. If you have any questions regarding the query process or today's program, please be sure to contact MRA. Thank you for participating in today's education. We hope you found it valuable. Here's a list of resources and references. Again, thank you for attending. This ends our program.